Assalamualaikum and good day to all postgraduate students. Welcome to the Bioethics Forum on Communicating Sensitive Issues. My name is Nurhanis and I'm from Department of Medical Education. As a postgraduate trainee, I'm sure that all of you have encountered a lot of challenging patient communications. And as a specialist later, you are expected to deal with this to a greater responsibility. And to prepare you through this journey, we have this forum today where we are going to discuss these issues in 3 rounds. In the first round, we are going to talk about communicating sensitive issues and cultural context. In the second round, we are going to talk about communicating undesirable or poor prognosis. In the third round, we are going to talk about issues on alternative medicine and unproven treatment. And to do this, we have 3 distinguished panels with us. And allow me to introduce our distinguished panels. Our first panel is Professor Dr. Shatria Ismail. Prof. Shatria is a senior lecturer and a consultant ophthalmologist, and her area of expertise include pediatric ophthalmology and strabismus. Prof. Shatria has been extensively involved with postgraduate training and has been teaching in USM for 27 years. Welcome to the forum, Prof.
Thank you.
Our second speaker is Associate Professor Dr. Azian Harun. Prof. Azian is a senior lecturer and a consultant microbiologist, and her area of expertise include medical mycology. Prof. Azian is also extensively involved in postgraduate training and has been teaching in USM for 24 years. Welcome to the forum, Prof.
Thank you, Hanis.
And our third speaker is Dr. Fahisham Taib. Dr. Fahisham is a senior lecturer and a consultant pediatrician. His area of expertise include pediatric palliative care, child abuse and child neglect. Dr. Fahisham is extensively involved in postgraduate training as well and has been teaching in USM for 12 years. Welcome to the forum, Dr. Fahisham.
Thank you, Hanif.
Okay, moving on to the first round, communicating sensitive issues and cultural context. I would like to ask Prof. Shatria regarding the first question. Prof, in our daily contact with patients, a lot of the times we have to ask or elicit sensitive questions like sexual histories, drug abuse, or alcohol abuse. And working in a developing countries where our clinics are very packed, our wards are very packed, sometimes patients can hear other patients' conversations. How can we best ask these kind of questions with such setting?
Okay, thank you, Dr. Hanis. Yeah, okay. I believe this is quite a technical issue for every one of us. It is not only in a crowded clinic. We also have a crowded ward at the current situation. Yeah, okay. I think the best option for everyone. Yeah, we need to have a proper, a more conducive area for the clinic. For example, at least we need a space. We need a room, preferably that is not exposed to other people, yeah, to deal with a history of sexual transmitted disease, substance or alcohol abuse, extramarital contact, for us to get a proper history. Perhaps in the ward will be much better because we would have like curtains, yeah, so we can pull the curtains and ensure that our communication is only confined with the patient. So we really need to speak in a proper way, in a proper language, so that we will not hurt the patient as well as could be the spouse as well, yeah? Especially when it comes to a sensitive issue like extramarital contact, for example. We need to explain to the patient as well as to the accompanying person that these are few sensitive issues that we have to ask you in order to help us for the diagnosis and the treatment as well. Yeah? And the language used should be not to accuse a person, rather than to get a true information, hoping that they are honest in giving the response. Yeah? And please avoid sentences that accuse the patient or blame the patient or create disharmony between the patient and the family members, for example. I think it needs a senior person. And again, this is an art of asking the history. Yeah? We should not be rely on the most junior doctor in the team. The senior person should come in and get the proper history. Yeah.
Okay, thank you very much, Prof. Shatria. I think that's a very important tips from Prof. Shatria, where we do not just set the physical setting, but also mentally we have to be prepared to ask the question in a correct way, not in an accusing manners. My next question to Dr. Fahisham. I think not everyone in this setting is trained in pediatrics, but along the practice, we have to deal with pediatric patients. And Dr. Fahisham, can you share with us what are the major challenges when communicating with pediatric patients? And in Malaysia, what are the major ethical or legal problems that we face when dealing with pediatric patients?
Okay, many thanks, Hanis. So when we are dealing with pediatric patient, basically we need to think about three kind of like people who are dealing in the communication. One is us, the second is the physician themselves, and the third one is the children. So which means that the way you're going to deliver the information, and also the way you communicate with children and also with the parents may be slightly different than the patients in adults. So for example, I mean, like if we take children, I mean, like children has got a diverse age group, neonates till adolescent, and the way they understand information maybe depends on the experience themselves. If I say, if I take a boy who's perhaps 5 or 4 year old, diagnosed with acute leukemia, and he probably presented to the hospital with the condition, the parents' reaction itself may mimic a worry, concern, and hence, I mean, the children kind of like reaction maybe is influenced by the parents themselves. So the way you communicate with children and parents may be slightly different. And subsequently, when they are getting older, the way you want to deliver the information also will be different. Maybe using diagrams, maybe using play, maybe using certain techniques that can make them understand better. So similarly to adult as well, because I mean, if you're going to talk to, I mean, I think a lot of us maybe worry too much about talking to parents, because parents are quite concerned and worries about their children. So when they worry about children, they've got a lot of anxiety, emotion, getting angry, and etc. And this, you know, perhaps, I mean, you have to understand their shoe. I mean, if you put yourself in their shoe as well, their concern, so that you become more empathy, you become understand of their context when they are, you know, dealing with such experience, and also as well, I mean, like different kind of like contextual what you call experience. For example, like if I were to talk to a parents with you know, child abuse, then the way you talk maybe would be different than when you're talking to parents who are facing, you know, grieving, loss of a child, or maybe when hearing a bad news, for example, like stage 4, you know, cancer or something like that. So I think, I mean, we have to be more you know, receptive and also sensitive to the surrounding, to the behavioral body language of the parents and also the child, and find the best way in order to make them understand better according to their maybe you know, social status and also their ability to understand the information.
Okay, thank you, Dr. Fahisham. I think it's when we talk about confidentiality, just now we talk about how to reduce confidentiality breach when talking to patients, how to cater sensitive issues when dealing with pediatric patients. But now in modern medicine, doctors are not working alone when treating patients. We are working with many healthcare professionals, and when in this setting we have WhatsApp groups, we have audits, mortality meeting, and sometimes we have a large-scale presentations when this is heard by hundreds of people, such as the CPC. My question to Prof. Azian is that how do we, in the best interest of patients, you know, wanting to discuss about patients, the richness of the history, but at the same time limit the discussion to the what's the important part and reduce confidentiality breach.
Okay, thank you, Hanis. That is a very important question actually. Yeah, as doctors, yeah, especially, yeah, or medical personnel, we are actually privileged, yeah, to a lot of patients' information, right? So patient most of the time, willingly share their sometimes secrets with you, yeah, or sometimes something that they do not share with other people, yeah. So we have to respect that confidentiality, yeah. Some are very important that cannot be hidden, and we are actually we need to respect that, yeah. We have to comply with the confidentiality, yeah, between doctors and the patients, right? So but anyway, we do not work alone, as you mentioned, yeah? We work with a group of people, managing team, yeah. Sometimes it goes beyond the department, yeah. So these confidential information sometimes need to be shared, yeah. And sometimes names and identification needs to be, yeah, shared with others as well, right? So in the first place, when do we share this information? Yeah? As you mentioned, it might be shared during audit or during CMEs or during CPCs. Yeah? So we need to understand who are the audience, who are the people that we are sharing the information with. If we are discussing things in CPC, for example, yeah, it's a very open, yeah, forum. Yeah? So we need to restrict a certain, yeah, information. Yeah? Of course, in CPCs we do not identify this patient as names. Yeah? And we try to cover. Yeah? If we need to show face or part of the face or body parts, yeah, that must not be identified to any patients. Yeah? But sometimes if we have Prof. Kshatriya's patient, yeah, the eyes, you need to, share with the audience a little bit of the face, yeah. But we have to our best ability, try to cover, try to make sure that the patient's identity is not shared with others. Yeah, that is for CPC. Yeah. For audits, for example, in CME, sometimes we need to share with our own managing team who are the patients. Yeah, the patients sometimes some findings sometimes needs to be shared among the small group, but we must make sure that who are actually the people that we are sharing it. Yeah, most of the time it is among the managing team. Yeah, so it is inevitable to share or to disclose the patient's identity in that kind of situation. Yeah, but another thing that I would like to highlight here is sharing or discussing patients' details and patients' management or whatsoever in a cafe or in when you are actually in the presence of other people, yeah, public, for example, in the cafe. Sometimes without knowing, we are sharing patients' details. Yeah, of course we mean no harm. Yeah, but sometimes without knowing, we are actually breaching that confidentiality. Yeah, and who knows that among the public presence there might be people who knows the patient. Yeah, sometimes we need not mention the patient's name, but sometimes you say, or this person or this patient in ward so and so, and then I saw this patient here and there. Yeah, so those are things that sometimes among medical practitioners, they thought that they are talking among themselves only, but little did they know that other people can hear them. Yeah, so and also sharing things in the SOCMED, social media. So it's the same. So we have to be very careful in whatever condition, that confidentiality thing must be maintained. Yeah, that's all, Hanis. Thank you.
Okay, thank you, Prof. Azian. I think that's a very important point. Sometimes we put a lot of emphasis in terms of our communications with patients, and we are very comfortably talking with our colleagues about the patients. And with this settings of WhatsApp, sometimes we forgot that things might spread beyond our circles of the treating teams. And bear in mind that there has been a recent medical legal case where confidentiality breach was made, and the doctors, the healthcare professionals were found guilty. So I think that's the end of the first round. So there's a popular saying that goes, to cure sometimes, to relieve often, and to comfort always. As medical professionals or healthcare professionals, we are not always the bearer of happy news. Sometimes we have to talk about undesirable or poor prognosis. And if not dealt properly, this may trigger a lot of anxiety, not just to the patients, but to the healthcare professionals. And in this round, we are going to discuss about this. My first question is to Prof. Kshatriya. Prof, you are a surgeon, and you very well acknowledge that when we do medical procedures or operations, sometimes complication occurs unintentionally, and sometimes errors occurs. So when this occurs, especially in the context of postgraduate trainees who are still learning, how do we communicate this to the patients, these unpleasant incidents?
Okay, thank you, Dr. Hanis. Yeah, okay. To discuss about complication is rather quite difficult. So better we explain to them during the pre-operative period. These are the potential complication that at least we mention to the patient first. If it does occur, then we have to manage accordingly. Okay, I think everyone will be telling your patient the risk and the benefit of your surgical procedure or your ward procedure. However, if any errors or any complication occur, the best is it has also a different magnitude. If, for example, from ophthalmology, let's say wrong eyes, that has been operated, that is quite a very severe magnitude that we can't be relying on the junior doctors. So the specialist in charge should be the one who convey and discuss to the patient. But before we do that, please bear in mind that again, there should not be your junior doctors, your nurses, to communicate to the patient first. We need to go as a team, comprised of a senior specialist, a registrar, medical officer, a junior medical officer, or even our staff nurse. So explain in detail, but it has to be in a proper way. We have to avoid certain phrases like "I'm sorry, wrong eye has been operated," or "we should not do this." Those are phrases that we should not inform to the patient. We have to make it in a rather more professional way, that explain to the patient, led by the senior person of the team. I would like to stress here, especially for the medical officer, never ever ask your junior houseman to break this news to the patient. This is the responsibility of a team led by the specialist when any complication occurs. Again, those complications can be divided into severe, moderate, and mild. I'm talking about a severe situation, wrong eyes or wrong leg or any other potential errors that could occur, or any severe complications occur during the surgery. So after the procedure, you have to complete the procedure as it is and sit down with the patient, sit down with the family members and explain in a calm mood, rather than panic situation. Let the senior person to discuss this, because it needs some kind of calmness, maturity, and plan what should be done next. Obviously, the patient, the family members will ask you, okay, what will you do next? Yeah, so we have to get a proper planning to explain, so that they will be able to accept. Yeah, if really something has to be undo, for example, yes, but the next procedure must be done by person who is expert or specialist. Yeah, the undo procedure cannot be done by a junior doctors who is still learning. Yeah, that is to avoid more complication. So at least in every surgery, I hope that the specialist will be standby, preferably to be in the OT with the trainees, to avoid these are the potential complication. We understood that can be happen, but errors could be something that public will take it as a very big issue. They can go to the media, they can write to the Malaysia Medical Council, they can go to the minister, for example. So that issue has to be tackled professionally at our level before it goes beyond it. And I'm sure in every hospital, every institution, you got to report on this adverse event during the surgery. So we got to write in a proper report explaining and be honest in your report. Again, it can be drafted by the juniors, but your specialist has to go through the report and ensure that the facts are correct. And in USM, for example, if we feel that the magnitude is quite severe, we can always talk to our lawyer, for example, to get some advice on the medical legal aspect, before it goes beyond our institution. So I hope that everyone will take note on this. We accept that complication can occur, errors may occur, but how we tackle it, how we overcome it, is the most important issue, and it has to be a team of people to take the responsibility. Never ever let your nurse to speak to the patient. Never ever let your junior houseman to tell the patient, for example. That should be avoided in all means. Thank you.
Thank you very much, Prof. Shatria. I think that's a very important point. Sometimes when we make mistakes, we want to take matters into our own hands, and we thought that we are reducing the number of people that know, but in errors or complications, Prof. Shatria has mentioned that this needs the communication needs to be planned, and it must be led by our seniors. Yes, Prof.
Please avoid not to mention, your surgery was done by Dr. A. Specifically mention the name. Whatever it is, we work as a team. Please remember that. We are not pinpoint on on Dr. A, for example. I'm not the one who do your surgery. That should be avoided at all. This is not individualized. We work as a team. You have your hierarchy, you have your consultant, your specialist, your registrar, medical officer. So please avoid mentioning names and pinpoint or blame on a specific medical health personnel. The fault or the responsibility should be on the team. And that's why if any incident occur, the head of department will be the last person to explain on these issues. Thank you.
Thank you very much, Prof. Shatria. For the next question, I would like to ask Dr. Faisham. Dr. Faisham, we all have soft spots for children. We want the best for them. But sometimes, as you mentioned, there's context. And sometimes what we want for pediatric patients may not be the one that their parents feel best for them. So how do medical professionals or healthcare professionals deals with these paradox decisions issues?
Okay, all right, thank you, Hanis. I think there are two things here. One is about communication, because I think as Prof. Shatria mentioned, communication is the key here in order for the parents to understand about what happened to their children. So that's number one. Because I mean, like, if you do not communicate well, therefore they might understand it differently, and there will be friction, there will be loss of trust, and that will be disaster for the medical team. The number two is the key here is the decision making. Because decision making in pediatric, it should be shared decision. It's not solely like adult, where you have autonomy, where you can make your own decision. I mean, like, if you can't, then somebody who's close to you make those decisions. But in children, solely it's more by proxy. So which means that the parents has to make those decisions. Bear in mind, all parents, I think we put aside if a case of child abuse or anything like that. So bear in mind, parents want the best for their children. I mean, those are the premise that we all should take. If a parents who thought differently, then you ought to protect the child from making those decisions. So at that kind of like juncture, we all should agree that the healthcare professionals, the parents, should make decision together. So we should be able to make a shared decision in order to achieve same goals. So what if there's a paradox of decision? So I'll give you an example. I mean, like, if a child who's got pneumonia and the parents want to AOR, kind of like discharge against medical advice or at own risk, kind of like discharge. And this is kind of like crucial, because I mean, like, if this is something which is can cause harm to the child, therefore I think it is our obligation of a healthcare professional to protect the child and safeguard the child from complication. And this is in line with the Child Act 2001 as well. So that's number one. But if there's a different scenario, for example, end of life, parents want to take home. I mean, they have their own wishes that they want to take their own children home in order to die at home instead of dying or place of care in the hospital. Then I think we should negotiate this, okay? Because what we don't want is that the parents to make such a rash decision without any support and causing more distress when they're at home. So I think we all have to look into context. I mean, like, what happened? I mean, what is it? I mean, if it's really related to the best interest of the child, therefore protecting the child is paramount. But if this is related to something where you know already that the disease progress, I mean, like, there was no cure, I think that's obviously has to be depending on the circumstances and kind of like discussion and support available for the parents. So I think those are the things that I think we should focus on. Thanks.
Sham has outlined two scenarios where one, the Child Act is applicable, and the other one when involving end-of-life decisions, that's a lot more complex, and at this case is the best interest of the patients that matters. Okay. Just now we talk about complications, errors, and paradox decisions. Sometimes in treatment of patients, for example, it also involves minor things, not to the extent of errors, but perhaps if I could give an example, now that our hospitals are a bit stretched, there's a lot of COVID cases, then there's now influenza and other diseases, and sometimes healthcare resources are stretched. And this could lead to longer waiting time, waiting for bed, waiting for operation, and sometimes this could affect the outcome of the patients. So my question to Prof. Azian is that in this kind of setting, how can we give comfort to the patients, especially in the times of social media where patients take it to the next level and sharing with social media? Thank you, Prof.
Okay, thank you, Dr. Hanis. Well, it has been this is our third year of living with COVID. Yeah, it actually has taken a toll on all of us. Yeah, many management, patients plan, sometimes a bit haywire, sometimes or a bit modified because of this. Yeah, for example, as Hanis mentioned. Surgeries, operations can be delayed or can be postponed because of COVID-19. Yeah, or certain things cannot be done, in time because of budget, for example. So these are all hindrance that we have to face. Yeah. So like it or not, we have to live with it, and then whatever we have to make the best out of that. Yeah. But when there is a change in plan, yeah, it is not. Sometimes it is inevitable. For example, because of COVID-19 cases, yeah, surgeries has to be postponed, and we have patients who has been waiting, yeah, for these operations, yeah, and for them, it's for their benefit, yeah. But if things has to be changed, yeah, or management plan has to be changed, yeah, it has to be communicated well to the patient, yeah. As Prof. Shatria mentioned just now, yeah, do not let your nurse or your junior officers to communicate with your patient, yeah. So whatever change in the plan, it must be communicated with the patients. Yeah, whatever conditions that we have in the ward that might, yeah, affect the patient, it has to be explained well. Yeah, I believe what we have, yeah, for example, false litigations and accusation on the social media, sometimes it arises because of the failure of effective communications. Yeah, sometimes if they understand, yeah, they would actually comply and they will not complain, I'm sure. Yeah, of course, sometimes we do have a lot of kinds of patients, yeah, who wouldn't want to tolerate, yeah. But as medical personnel, so we try our best to deal with this patient. Yeah. So, but for you also mentioned in A&E, sometimes waiting time is very, very long. Yeah. In clinics, also waiting time is very long. We deal with a lot of patients. Yeah. So we need to try to make our patients understand. Yeah. And this is not a one-man show. Yeah. One doctor cannot do that. One nurse cannot do that. One clinic sister cannot do that. Yeah. Or the head of department himself or herself cannot do alone. It is a concerted effort by everybody to educate our patient. Yeah. Yeah. But do it properly. Yeah. But when it comes to important decision, yeah, correct person must do that. Yeah, so I think that's all, Hanis.
Very much, Prof. Azian. I think it is evident when all of our speakers echo the same thing when talking about unpleasant complications, errors, paradox decisions, or waiting time. It is not proper for us to let the other person do it. It needs a concerted effort, as mentioned by Prof. Azian. Led by our seniors, if possible, and also need a lot of thinking, as mentioned as Dr. Fahisham. So I think moving, just now we talked about unpleasant scenarios, and moving on to the third round. In the past, patients come to doctors and expect treatments to be suggested by doctors. But now in this modern era, normally, not normally, but a lot of the times, patients come knowing like what are the other alternatives available. Sometimes they know from Googling, or sometimes from their family member suggestion and so on. And of course, doctors on the other hand are going towards the evidence-based medicine. So sometimes we are going in a different directions, opposite directions. My question to Dr. Fahisham, sometimes we hear, parents opting for non-standard treatment like BOMO, shaman, in cancer patients. And of course, we want the best for the patients. So how do we approach this, especially when involving, like you mentioned just now, life-threatening conditions or life-limiting conditions? Yeah.
I think this is a very difficult kind of like scenario where if you're going through, because I mean like often day in day out we are going to see type of cases like this, and often I mean like, because I think primarily because if you are facing some life limiting condition, you're still going to have some hope, and what you're hoping sometimes may not be realistic. And that's where, you know, because I mean like some of our communication, the way we communicate to the parents or to the patients, we kind of like how shall I say, abandon them. So the words that we put into our mouth to them, and causing them to be feeling abandoned, and therefore they will seek for other alternatives. So which means that non-standard items, for example, like in my case, I mean like I remember I have a case, a child who basically has got tumor in the intra-abdominal, and unfortunately the dad used kratom or ketum basically as a substitute for morphine, although I keep on increasing the morphine. So then what should I do then? I mean like, because I mean like you know, in that scenario you are bound also to the legal aspect of it. Imagine if somebody is using, you know, street drugs, morphine, and you know about it. Okay, I mean, like morally, ethically, as a medical practitioner, what do you do? I mean, this is also a dilemma between us as well. So because I mean, like whether should I report? Should I not report? What happened here? Okay, so I think. I mean, in that scenario, I mean, I'll just take back to my scenario. I mean, this is a very, very difficult circumstances when you know things that which is non-standard item, like for example, like ketum being used for a child. I mean, we recently we look at the what you call all these you know, father trying to give vape for a child. You know, these all very fiery kind of like discussion, and very you know, because you want to protect the child from getting the aftermath or the harm that was done by the parents. So then I mean like there are one other rules that we use. I mean like, although we look at the best interest of a child, there's one other rules that I always put at the back of my mind, which I call it the zone of parental discretion, which means in the ethics we have a zone, I mean a border between benefits and also harm. And sometimes in the benefit section we got a couple of options, maybe option number 1, option number 2, option number 3, and sometimes it doesn't really reach harm. And if it doesn't really reach harm, so I think, you know, sometimes it should allow. I mean, like I often allow, you know, they call it the zone of parental discretion, because I thought, you know, if the parent is responsible, taking a good action, but then like they felt that they're grieving, sometimes they're denial, and sometimes they are still hoping for the best. But their hope, unfortunately, they're not, you know, realistic at that point of time. And that's where they search for it, and therefore sometimes, as long as there's no harm intended to the child, I mean in terms of child protection wise, I would allow. That's my what you call decision at that point of time. So you need to look at the overall picture. I mean, whether there's a trajectory of the disease itself, whether the child is coming, you know, kind of like slowing down, and then you look at the potential side effect, and also I mean like if it is really causing more you know, not harm, so therefore I would allow it. Although sometimes I mean like at the back of my mind or in my heart perhaps I mean like, because I keep on thinking about the concept of God watching me whatever I'm doing, so therefore I mean sometimes we all have to be aware of our decision as well. So I think that's it then. Okay,
Thank you very much, Dr. Faisham. I think there's a very interesting approach where when we encounter this situation, to ask whether that alternative treatment may cause harm to the patients, and whether there's a flexibility that we could offer when it's not causing harm. I'd like to extend that question to Prof. Shatria. Prof, as an ophthalmologist, you're involved with the eyes, and this is a very important organs for us. So perhaps, Prof, in cases where patients might lose daily functions, for example, their eyesight, and they wanted to try out something else, other alternative treatment, or they do not want to proceed with the suggested treatment, how can medical professionals or healthcare professionals approach this?
Okay, thank you, Dr. Hanis. This is quite a difficult situation in the clinic, yeah, because they do have their own belief, yeah, or someone may tell them certain kind of stories that it works for them, yeah. So what we should be, I would advise every junior doctors that, okay, at some extent we need to respect, yeah, at least you give them for them to voice out their opinion and be a good listener. Then we can start informing them, okay, as long as, for example, these are not evidence-based medicine, we are not sure about this, but in certain condition, if they want something like vitamin, for example, for the eyes, and they need, so as long as those options of treatment do not cause any harm to the eyes, yeah, I said yes, yeah, they can try on, but again, there's no evidence-based medicine, yeah, compared to what we had been trying to help them is proven by various studies, in fact, according to the guideline for certain diseases. But again, as a human, we have to respect their opinion, give them a bit of room, as long as they want to try. But most of the time when they come back to see us, they will say, okay, they have tried for 2 months, for example, there's not much of change. So I have no issue with that regards as well, unless they are in a situation that they really need a medical treatment or a surgical treatment and they refuse. For example, they have a very poor vision because of cataract. Yeah? Cataract is a reversible condition that can be treated with modern treatment, but they insist not to do that. Yeah? So I would suggest for the doctors to give them a bit of time. Sometimes our diagnosis, our advice may be a shock to them. Yeah? They are not ready with that. They may, especially in elderly, they don't have their children who will support their diagnosis. Yeah? They may not be in the best condition, yeah, with their education level, for example. So we can always see them in another 2 weeks time, with their family members to come over, so that we can always re-emphasize the need of modern treatment. Do not allow them to go back with no further appointment ahead, so that we are actually leaving them in the dark. Give them a bit of time. I'm sure they will be agreed to our treatment. Get their children to come together, their close family members, so that the next of kin will be able to support their treatment, I think. Thank you.
Thank you, Prof. I would like to extend the question. What is different? Is there anything different in terms of documentation in this kind of scenario? Because sometimes this could be an issue afterwards, not by the patient or maybe by the relative themselves. So how do we protect ourselves in terms of documentation?
Yes, I think good documentation is very mandatory. So we could always write in the folder, explain about the modern treatment, yet patient refuse and opt for medical treatment. For example, explanation about pro and cons has been explained clearly to the patient. Advise the patient about the modern treatment. I think please write clearly. Just I would like to add another issue, like Prof. Azian mentioned just now about the surgery can deferred for certain reason. I will always emphasize to my trainee, when you call a patient to come for our appointment pre-op, for example, you are not able to get them, write in the folder that you have a time to make a call to the patient. What is the number that you call? what was the time of calling and who did the calling. Yeah, please write. At least this is a documentation. Because they may change their phone number. It is not that we do not trying to get them to get an early appointment for surgery, for example, especially when we change the date of surgery. Document in the folder. Even though you do not get a positive response from the patient, those documentation must be available in the folder.
Okay, thank you very much, Prof. Shatria. My last question to Prof. Azian is that just now we talk about talking to patients about alternative medicine. Sometimes we feel that we try to give the best for the patients, but yet they choose alternative treatment, and then they come back with a severe stage of disease, and causing much more treatment needed from our side. So my question, Prof, how do medical or healthcare professionals face patients who has refused standard treatment and now coming back with needing much more care? So are we allowed to impart our feelings to them? Yes, Prof.
Thank you, Hanis. Okay, patients refusing standard treatment, we got it every day sometimes, as Prof. Shatria and Dr. Faisham mentioned. When patients refuse, we cannot leave them alone. We must make sure that they really understand what they are going through, what treatment modalities that we are offering to them, and the pros and the cons. So there's no harm of spending a bit more time with them to make them understand. So they need to understand what they are refusing. What kind of complications if they refuse the standard treatment, and have a respect for their belief, and they are nowadays they are exposed to many things, in the social media, their friends, elsewhere, telling them that a certain treatment can be done, or certain alternative treatment is available for them, and there are many testimonies. You can just Google it, so you'll find a lot of things. So our patients may so-called refuse our treatment because of their belief in the alternative treatment. So what we can do is, number one, not being judgmental. Do not be angry with the patients. They might refuse and then come back, with a more severe condition. Still, we cannot be. We have no right to be angry with them. Maybe we are not doing our job in explaining to them the first time. So always reflect that. So it is, of course, easier said than done. So sometimes because we need to spend more time with them, not only the patients but also with the family. So because family also affect those decisions. So and especially in Kelantan, you have sometimes the mother, the father, the grandmother, the great uncle. So everybody need to give their opinion. Respect that. Respect that. Right. So try our best to give proper explanations with evidence. So because they need to know what are the chances as well. Of course, we can say that nobody can guarantee 100%, but this is the standard treatment that is currently accepted, all over the world. Something like that, right? So, but bottom line, communication. Communication, effective communication is vital here. So, but good communication cannot be made. If we are not trained to do so, or sometimes in a busy clinic, and nowadays everybody is tired, in a busy ward, everybody is exhausted. So how can we ensure that we can communicate well when we are not in the condition to do so? Yeah, so a lot of things need to be done. Yeah, to avoid this. Yeah, so we have all the information with regard to the treatment modalities. Yeah, but we cannot convey well because maybe we are too exhausted. Yeah, to spend more time with the patients. Yeah, so what can be done? Yeah, yeah. So of course I cannot, offer more medical officers to be placed in Dr. Fahisham's ward, for example. Yeah, I cannot do that. Yeah, but I'm sure there will be communication between the wards, yeah, the departments and the hospital administrators, yeah, to make sure that patients' management is not jeopardized, yeah, because of that. Yeah, all right. So same goes to something that is hot. Yeah, during COVID-19, yeah, anti-vaccines and something like that. Yeah, so of course we have our own opinion, but other people also have their own opinion. So we respect their opinion. Not necessarily we agree with that opinion, but it is our job, yeah, to make sure that everybody, yeah, be aware of the benefits with evidence and whatnot. Yeah. Thank you, Anis.
Thank you very much, Prof. Azian. I think that's a very important point to reflect whether we have done our job well in educating them in the first place. We have a very good sharing by our panels, and from the discussions in these 3 rounds, I think there's a lot of important and practical tips. And the general tips that I've gathered is that when communicating sensitive issues, we have to plan, we have to look at the physical setting. Is it appropriate? Is the patient ready for the communications or the dialogue? Number 2 is that to understand the context of the patients, as Dr. Fahisham has mentioned repetitively, like what do they want? And number 3 is that to spend time educating patients. So patients is not something to be someone to be seen and passed within few minutes. They deserve the education that they need because they are making important decisions about their health and sometimes their life. And number 4, I think although trainees sometimes are very scared, but when communicating sensitive issues, a lot of the times it is best to get seniors' help, to get seniors' advice on what's best to do. And before this session, I think some of our participants may think that this is just communication skills forum. But I think after listening to all these discussions, we are aware that there's a lot of potential challenging encounter that could occur, and I hope that we all take seriously about communication skills, and as we take communication skills as important as our clinical competence endeavour. I'm sure that our participants have a lot of questions to ask to the participants, so I would like to end the forum now. I would like to thank all the panels for their inputs and their insights, and thank you very much to all participants.